going to start your recording now.
All right, everybody. Well, good morning and welcome to East Orlando Chambers Healthcare Collaborative. We've got 3 things you should know today with physician practice value-based care. It's the key to success in moving forward. So we are powered by PowerNet, who is a full-service IT firm that specializes in data security, monthly managed service, and contact center solutions. They can help with a single project, or they can function as your IT staff, or anything in between. Today we are featuring...
Oh. What happened?
Andrew, we've lost your audio.
Love it. Sorry about that. This thing is scrolling away, and can't seem to stop it from scrolling. But Fraser Cobbe also is the president of Cobbe Consulting and Management, and our wonderful host here, who's no stranger to everyone, John Kelly with Orlando Medical News. So we're very excited about him. He does have a podcast and a radio show on AM 950 or FM 94.9 on 1 p.m. on Saturdays. So I've been on that, and I encourage you to tune in and listen to that. And also want to just make sure that everybody is aware of our trustees. Our trustees are Advent Health, Avalon Park Group, Avalon Insurance Services, Duke Energy, Great Florida Insurance of Hunters Creek and now Lake Nona, the Orlando Law Group, Orlando Health, and the Suburban Land Reserve. And we also want to say thank you to our partners who have helped us put this together. Orlando Medical News, the Physician Society of, Physician Society of Central Florida, the Health Council of East Central Florida, Social Media for Doctors, and Insight Marketing Group. So we want to thank all of our partners to help put this programming together for you. We want to make sure that it's meaningful and has purpose. So without further ado, John Kelly, I am going to give this over to you to take it away and introduce our folks and to go from there. So without further ado, thank you, John, for being here.
Thank you, Andrew. You know, how we got here, a couple of months ago, we were privileged to be joined by a state representative, and he was presenting while legislation was in session. The question was asked near the end of the program about healthcare's transition from fee-for-service to value-based healthcare. And to this representative's credit, he admitted he had no knowledge. And so immediately I spoke with knowledge of the transition, especially concerning since we're in a state where Medicare is such a big part of our healthcare. We're in heaven's waiting room after all. And so I reached out to Andrew and said, we need to do something with this. And here's where we are today. I was able to recruit 2 gentlemen that I have great respect for, and they are leaders in the industry. Joining us today is Larry Jones, who graduated from the University of Georgia. He's an absolute bulldog, both in football and healthcare. Larry is the executive director of the Integrated Independent Physicians and CEO of the Independent Healthcare Partners headquartered in Maitland, Florida. The IPA, known as IPN, is an approximate 1,000 physician multi-specialty network throughout 12 counties in Central Florida. Its core mission is to provide tools and programs for physicians to compete in today's challenging healthcare environment. Today, IPA oversees 2 commercial ACO contracts, and its MSO holds 5 Medicare Advantage agreements, representing several thousand Medicare members. Larry has been on both the payer and provider side of healthcare. He understands healthcare, its challenges, and its opportunities. Larry is recognized nationally and speaks all over the country on physician issues and opportunities, including the former Trump administration Larry met with. Larry is the ultimate physician and patient advocate. Larry is also the impetus behind our successful Healthcare Now radio show. Larry told me I had to get a plug in for that. We are also joined by Fraser Cobbe, who is the president of Cobbe Consulting and Management. Fraser is a political science major from Florida State University. He's really excited about Mackenzie Milton joining the program. Got your plug in there, Fraser. He currently serves as president of Cobbe Management, Consulting and Management, an association management company that specializes in managing physician and medical executive organizations. Fraser has served as the executive director of the Florida Orthopedic Society, better known as FOS, since 2001. Fraser formed Cobbe Consulting and Management, which currently represents 10 physician and healthcare organizations. The Duval County Medical Society, the Dade County Medical Association, Bone Society of Florida, the Florida Orthopedic Risk Purchasing Group, the Georgia Association of Orthopedic Executives, Bones of Pennsylvania, Midwest AAOE, and the South Carolina Orthopedic Association. Fraser began his career on the staff of the Florida Medical Association, better known as FMA, and has served on the board of directors of FMA, as well as the FMA Political Action Committee. Welcome, Fraser.
Thank you, John.
I'm going to start out with Fraser. Your questions are I've never seen anyone prepare as well as you did. What is the sense of your physician members in relation to the drive to advance value-based care?
Fantastic. Thanks very much for that question, John. And I'm really pleased to be with y'all. I've had the pleasure of working with the Orange County Medical Society for a number of years. And then, of course, we transitioned into the Physician Society of Central Florida to combine all the local organizations. So as you heard from my bio, I'm a physician advocate. So I guess just a disclaimer, most of my comments today are going to be based from the perspective of physicians as they try to navigate the new reality that they face with the implementation of value-based healthcare. So I don't have the experience Larry does from a panelist standpoint. He'll be able to talk to you a little bit more about, the operationalizing contracts and relationships with carriers. But what the perspective I wanted to share is how, the feedback we're getting from our physicians during this transition, what challenges they're looking at in competing in a value-based world, at the same time managing a fee-for-service world during the transition. So as far as the perception that we're getting, it really depends on where physicians stand in the healthcare delivery system. Of course, there's many practice models that physicians can choose to go to. It's easier, of course, if you have the infrastructure and support of administrative staff and additional resources to dive into the value-based care programs, because they take a lot more complexity, a lot more access to data and resources to manage. So there is a feeling that some of the smaller practices, of course, are left out of those opportunities. And we'll talk a little bit later about the role that insurance carriers play as far as a contracting standpoint and somewhat picking who they invite to dance to participate in those contracts and agreements as well. So again, it really depends on where they stand in the system. We have seen, of course, in order to position yourself to take advantage of the new payment models where you see that fee-for-service reimbursement is dwindling and more resources are being piled into value-based reimbursement. We've seen physicians coming together and consolidating either under umbrella groups or just larger networks as Larry has put together, or joining hospitals and health systems. And of course, venture capital is out there as well to provide funding to enable you to compete in this new arena. And certainly that consolidation is not a new phenomenon, but the more we get into value-based healthcare and the need to have more infrastructure to survive and sustain, it's certainly helped accelerate some of that consolidation. So again, it's a mixed bag. The sense of our physicians, it really does depend on where you stand. There's some physicians that are in institutions that have had great success in this model and are pleased with it. They're getting support from other non-physician practitioners to help them deliver healthcare, do more of the patient outreach, patient management that's required to make sure you're performing well in these programs. But again, there's a number of physicians that feel a bit on the outside looking in. Let me leave it at that, John. Yeah.
Larry, you've been involved in the value-based movement for years. So from your perspective, why is it so important to physicians in the U.S. healthcare system?
John, it's important to understand where we are today in our U.S. healthcare system. The U.S. healthcare system today spends about $4 trillion a year on
Hey,
patient.
Larry, can I interrupt you for a minute?
Uh-huh.
Can you turn your mic up just a little bit?
Okay. All right. How's that? Is that better?
That is.
Okay. You know, we spend about $4 trillion a year on healthcare in the U.S. And if that were a country, it would be the 7th largest economy in the world. And the average family premium today is approaching almost $2,000 a month. And out-of-pocket costs for patients have doubled in the last 10 years. We're approaching 20% of the GDP, the gross domestic product, and that is going to be completely unsustainable going forward. And it's estimated by 2030 that $4 trillion will move to $8 trillion in our U.S. economy and represent 25% of our GDP. We have to move from practicing sick care in this country to practicing preventive care and wellness patient care. Employers and consumers, including patients, cannot continue to absorb double-digit rate increases day in and day out. And physician reimbursement, as Fraser indicated earlier, is fee-for-service is dwindling, and physician reimbursement for quality outcomes versus fee-for-service medicine will become a much larger piece of their revenue moving forward, John.
Fraser, can value-based care be effective in your opinion? Because I know that the administrative burden is really a challenge for smaller physicians, especially independent physicians that do not have all the resources of hospitals. Can you speak to that?
Yeah, thanks, John. And that's, I think, the million-dollar question, right? Because as Larry pointed out, our current path of increased cost continues to go up. And so everybody is searching for solutions on how to lower costs in the system. And so we've created the value-based programs as a way to try to get our arms around it and drive costs down. But in doing that, it's added layers of complexity. And I'm gonna show you a graph on my screen since I can't do PowerPoint. But Larry mentioned almost $4 trillion we spend on healthcare. If you can see this, that big red piece of the pie, that's 73%. That goes to non-medical providers. So of all your spend, your 4 trillion, over 73% is not actually dedicated to actual care being rendered to patients. So for the physician chunk of that pie, by the way, is only 7.3%, as Larry mentioned. That's a dwindling number. So here we have, and we have a bunch of business folks on the line too. How do you provide a service or deliver a product at a lower cost with a lot more regulation, complexity, infrastructure, and expense you have to put in to delivering that product? So that's going to be the key. Can we create systems that eliminate waste and duplication in services, even though we're spending more on the front end to deliver that care through administration and complexity? Will we find enough savings in the system to lower cost on the back end? I think all physicians agree that we have to deliver value in the system, and we have to drive the waste and the duplication out of the system. But how complex are we going to make that system to be able to deliver that to that product? And also to that end, we're kind of a little schizophrenic, because at the same time we've got the whole concept of eliminating all the middlemen and going direct to patient contracting, direct to employer contracting, and trying to trim some of the administrative waste out of the system. So as physicians, if you sit back and we're being asked, or we're promoting dual concepts, if you will, that's come together, that's create value-based systems that take a lot more operating capital administration on one hand, yet let's do direct primary care, which is certainly the right thing to do as well. And let's try to just streamline and make that relation one-to-one between a physician and a patient, or a physician and employer. So we do have dual lane concepts going at the same time, if you will. There's probably a role for both of them to a degree. But as a physician, when you look at it, you've got to figure out where you're going to spend your resources and your time and energy on your workflow and your practice design to determine, are you going full in on value-based? Are you going to carve out a little bit of a part of your practice for direct to patient primary care, or transparent services direct to the consumer through a specialty network? So, I mean, it's kind of interesting times, but I think that the end goal is the same. We have to lower costs in the system. It's going to be interesting if the more using big data and more complexity and risk sharing is going to drive costs lower versus more streamlined care.
Larry, you actually have been a proponent of value-based healthcare for years. In fact, you actually patented um, value-based IQ with the government. I'm going to ask the same question to you because you're right there with the physicians whose boots are on the ground, and you understand the backside challenges. That chart that Fraser just held up a minute ago, can you pick that up again, Fraser? That chart?
This one?
Yep, and that chart of administrative fees, how can the independent or small physician be successful understanding that burden, Larry?
Yeah, John, Fraser brought up a very good point. We can't make the future of healthcare so complex that it can't be delivered in an appropriate manner. I made the comment earlier that we need to move from sick care to preventative and wellness care. It's interesting that 65% of patient visits in this country are performed by primary care physicians, yet less than 10% of the overall cost is related to that 65%. And when Fraser showed that 73% chart, that's where the conductor, meaning the primary care physician, has to be a bigger engaged physician in managing this patient care. We need to make sure that if I were a physician with 4,000 charts, and I would say 20% of those have significant chronic illnesses, you want to have programs to keep these people out of the ER on Saturday night for a bad cold, which you're running up a $3,200 bill on average. If you go to the primary care physician or even an urgent care center, that $3,200 becomes $150. And so it's all about managing admissions, readmissions, ER visits, and making sure that we're providing the right care at the right place at the right time for an appropriate amount of money, John.
Larry, I'm going to come right back to you now because that primary care provider is the conductor.
Right.
But he is also the most underpaid part of the system. I believe in the Central Florida market, the average income for a primary care provider is about $150,000. Lordy, we've got salespeople that easily make more than that. This system appears broken.
Yeah, and John, you're absolutely right. Primary cares are on the low end of the income spectrum, but value-based care, if it's done appropriately with shared savings and surplus, meaning shared savings in the commercial world, surplus in the Medicare world, physicians have an opportunity if they transition their practice from a fee-for-service to a value-based practice to become an in-demand, high-performing practice, and as much as 50% of their income moving forward can be not just transactional fee-for-service reimbursement, but shared savings, outcomes-based reimbursement for the physician.
So you believe there is an opportunity?
I believe we can level the playing field with primary care, who is the conductor, the old name gatekeeper. I believe we can level the playing field and move more of the healthcare dollar to the people that are actually orchestrating care, meaning the primary care physicians, with the models of value-based care, whether it's a commercial ACO, whether it's a Medicare model MSO, or Medicare ACO, or even a MSO, meaning the Medicare Advantage program, which represents 28 million of the 60 million Medicare beneficiaries in this country are in some kind of a Medicare Advantage or Medicare HMO program. And that's where these narrow networks begin to play. And Fraser kind of indicated about that as the models and how do we keep our independent physicians involved and active in these models versus getting shut out in a narrow network. It's all about becoming an in-demand, high-performing physician practice.
John, and can I follow up on that point? I mean, we realize there's no more money coming into fee-for-service either. And if you look at Medicare, they've been working on a budget-neutral basic standpoint for the last number of years. So every year, physicians are faced with cuts in their CPT codes, and it's a bit of whack-a-mole as they move money around to make sure that the total spend from Medicare stays at the same level it has for years. And for you guys that run businesses, you know what a challenge that is to stay on a revenue-neutral standpoint over a series of years. It's just not sustainable. So really, the government is forcing folks into these value-based care programs, because simply by not putting any more money in fee-for-service. So the only way you're going to increase your revenue is to participate and try to take on risk in some of those risk-bearing models, and then reap the rewards, as Larry has mentioned. So they really are forcing physicians to look at those models, to drive them into them, and using the power of the purse to do that, because they're just not going to increase reimbursement on the fee-for-service side moving forward.
Thank you, Fraser. Something I've been trying to wrap my arms around for the last probably 2 years. What role does data play today in value-based healthcare?
Yeah, and I'll take that. And Larry is probably the better one to answer that question, since he's actually doing it and helping, his physicians navigate these contracts. But there's a ton more data available than ever before, obviously, and that's across markets. And healthcare is no different. So we do have more access to data, but it's limited data. It's a lot of claims data currently, which is one of the benchmarks that are really cost. Benchmarks that students have some concerns around. The bigger question around data, and data will continue to be more accessible moving forward. You've got a lot of actual transparent requirements coming out from the federal government too, that's going to make insurance carriers share more of their data, your commercial carriers, as well as the hospitals that are already under that. But the challenge we still have is that data is hidden in silos. So EMR systems don't talk to each other. Health systems like to keep that data of, obviously, their quality and outcomes data to themselves. So while data is super important and there's a lot of it out there, I don't think we've gotten to a point yet where we can put it to the most use, because it's still siloed off and somewhat protected within integrated networks or within health systems. So there's no cloud out there where a independent physician practicing in a community would be able to figure out the history, past tests that a patient has had when they walk in the door. Their medication roles to some degree are reported by the patient, rather than a cloud of data that they can pull into. So at some point, the government is forcing folks to share data more freely. But at this point, there's a lot of data out there. It's just not being put to real effective use across the system. So again, there's some winners and users if you can access the data within a clinically integrated network. Obviously, that's the key to success in these programs, because you need to know what each patient is costing you, and be able to intervene and direct them to use more appropriate cost centers. Again, as Larry said, the right care at the right time in the right place. So data's out there, it'll become more available, but it's still somewhat siloed off at this point.
Fraser, we could probably do the whole show on data, but it's important that when we have 7 value-based programs, and it's important we have a complete data team of about 20 people in our organization that do nothing but submit data to our practices on a regular basis. But it's about providing actionable data in not an overburdening way. In other words, we develop what we call a physician scorecard, and it might be with a primary care, it might be with specialists, but we certainly tie it to the primary care doctors, and it's got to be actionable data that isn't overwhelming. And 5% of their patients probably represent 50% of their cost. We know that. 4 out of 10 Americans today have at least two or more chronic illnesses. And it's all about managing these chronic illnesses. And even the people that don't have chronic illnesses today, managing their lifestyle and their preventative and wellness to make sure that they don't end up with chronic illnesses down the road. That's where I believe our healthcare system has failed. We're providing sick care today. We're not providing preventative and wellness healthcare. And it's all about everybody in America needs to get that baseline annual wellness visit every year and get your labs done so that think of it as a car. That's your annual checkup every year on your car. And if there's something going on in your car that needs tuning or replacing, that annual wellness visit identifies that. And then, of course, all the reimbursement and the coding that goes along with that for the physician to be able to have the money to impact the claims that are going to come in as a result of the cost of care. That's what value-based is all about. It's about managing patients in a preventative manner versus addressing acute care.
So Larry, what I'm hearing you say is that we really need to re-educate the American healthcare consumer, because the American healthcare consumer is more focused on sick care. And we need to re-educate the American healthcare consumer to be proactive in preventative healthcare. Am I correct?
Yeah, John, we spent a lot of time in our healthcare show. Healthcare Now is all about educating, helping people become educated healthcare consumers. And that includes many things. It not only includes, do you understand the benefits of your health insurance and how to use them in a more cost-effective way, but does your physician and all the providers that you go to understand your benefits and how to maximize your care but minimize your cost? A good example, having an imaging procedure done. You go to an MRI in a hospital, it's going to cost you $4,000. That's what the bill is going to be. If you've got a 20% copay, what's 20% of $4,000? Do the math. If you go to an outpatient independent imaging center, that $4,000 MRI is going to probably cost you about $600. You do the 20% of the $600 and look at the difference. And if you're on a health savings account today, or you have a high deductible health plan, which most people do today, the average deductible health plan in America is over $5,000 today. So you've got to know how to manage your out-of-pocket costs to where you're still getting the quality you need, but you're minimizing your costs.
So what I'm hearing you say, and correct me if I'm wrong, it's a three-part solution. We've got the actual patient consumer, and we need to treat healthcare and shop our healthcare just like a consumer does when they're buying a car.
Exactly.
You've got the provider, which is the physician, and then you've got the insurer, the payer.
Right.
On a radio show 2 weeks ago, we had Dr. Mark Howell, who's basically running Cigna in the state of Florida. Are we seeing support from the payers?
We have 2 commercial ACO contracts, which represents about 60,000 lives. And, we have actually performed, when you look at the overall cost of the payer in a region, anywhere from 8 to 10% below their overall market cost in our IPA, because we're independent physicians. And as Fraser indicated, what I said is the right care at the right cost at the right place. We help our patients understand, we help our doctors understand how to manage these patients in a more cost-effective way. That's what value-based care is all about, John.
Fraser, I'm going to come back to you because you've had a lot of experience working with the Florida legislature. I mean, you were with the Florida Medical Association early on. You've got some deep roots there. How receptive is the Florida legislature to doctors as they attempt to move from fee-for-service to value-based healthcare?
Yeah, I mean, the best way for me to probably answer that is I guess that's a work in progress a little. It's somewhat reluctant. As we heard from the legislator last time we were together, a lot of these discussions around value-based care program designs are happening at the federal level. So the state legislature has not really dove into them from a structural standpoint, but they need to understand the decisions they make on care delivery and can regulate as far as state statutes impact physicians' ability to be successful in these models. Years, Stark rules, and we could do a whole nother program on Stark that really was preventing physicians from having any financial incentive in ordering tests and doing things that they feel may be in the best interest of the patient, but yet they have ownership, so they weren't allowed to do that because we can't really. The feeling was that physicians would overutilize. That whole overutilization fear has gone away in these value-based programs because the physicians are managing the total care of the patient and the total cost. So those restrictions need to be relaxed, and they are. We had a stark rewrite on the federal level this past year that recognizes that physicians need to take ownership in some of these services, these ancillary services. And as long as we're reimbursing them in a manner that takes away the capability to abuse from a fee-for-service standpoint, that physicians should be able to utilize those services, should have ownership in it, and should be able to reap some of the rewards from it. So more needs to be done on a state level because we still have the state level self-referral laws that need to be looked at, but also small things like a couple of years ago, the legislature did help by passing a law that allowed physicians to stay in a surgery center for up to 24 hours. So that was 24 hours from the start of the procedure, not just having to leave the ASC at midnight, which was the previous law. And so that helped. Not that we're going to do a bunch of surgeries at 8 and 9 p.m. in the evening, but if you do one in the afternoon and the patient needs a little bit more time to recover, having an arbitrary deadline at midnight to kick the patient out or refer them or send them over to a hospital to continue their rehab made no sense from a cost standpoint or from a patient care standpoint. So the legislature did come in and allow up to 24 hours from the start of the procedure for a patient to stay in a surgery center. And that helps because surgery centers clearly can offer procedures at a lower rate than you would for an inpatient procedure or even hospital outpatient procedure. So there's little things that they can do to affect, but some areas they're falling short. Just this past session that just ended 2 weeks ago, there was a discussion about using telehealth for prescribing controlled substances. Currently, during the executive order, physicians are allowed to use telehealth and prescribe controlled substances. Once that executive order expires, we revert back to current Florida law, which prohibits all controlled substances prescribing via telehealth. So you think about what we've learned, the benefits of being able to quickly intervene with a patient and prescribe, if it's a pain med, quickly prescribe that to a patient so they don't have to try to travel across town to see you. If you're a regional care center, a center of excellence, you've seen a patient, you send them back home. This would allow them to actually see them via telehealth and prescribe medications without requiring that patient to travel to your office to receive just a prescription. So unfortunately, that bill didn't pass. So once the executive order expires, we'll be back to the original ban on using telehealth for controlled substances. But there's small things like that they can do to just provide some freedom for physicians to work within these systems to deliver the right care at the right time. That would be helpful. But to a large degree, our state legislators have not gotten to the point of diving deeper into how they can help us operationalize what we're trying to do.
Yeah, John, just to expand on what Fraser's saying, I spend a lot of time in my team dealing with Washington and dealing with the legislators in Washington, CMS, CMMI, HHS, and some of the MedPAC group that makes a lot of recommendations on the Medicare, Medicaid programs for Congress. And there is no question that reining in healthcare costs is a bipartisan issue in Washington. Everybody understands that this has to happen. It's estimated right now that the Medicare Trust Fund will be insolvent by 2024. And if that in fact happens without legislative intervention, we're going to be in a mess with 60 million Medicare lives. And between now and 2030, there will be 2 million more Medicare beneficiaries adding to the role of Medicare each year for the next 10 years to take us to almost 80 million Medicare beneficiaries by 2030. And then you've got the Medicaid program. You've got 17 states in the country that have not expanded the Medicaid federal program for obvious reasons, and Florida is one of them. It's all about cost. You know, we just passed in Florida under DeSantis a $101.5 trillion budget. I'm sorry, $1 $101.5 billion budget in Florida. And a significant piece of that went towards Medicaid. Medicaid represents almost 40% of our total state budget in Florida. But the legislators in Washington understand, and CMS, the Centers for Medicare and Medicaid, as well as the Innovation Center, are trying to come up with these new programs, as Fraser indicated earlier, that to build new models that drive not only organizations but physicians into risk. That and you know, in my opinion, as a physician advocate, physicians didn't go to med school to become insurance companies and take on risk. They became physicians to treat patients. And there's a balance and a fine line there between passing on risk to physicians and moving to a value-based environment. We could have a whole conversation on that. And I see Fraser shaking his head and agreeing with me. But the bottom line is Congress and our legislature does understand that we have to get a rein in on this healthcare cost, or our economy is gonna be in a mess.
Yeah. John, can I add one more thing? I should give the Florida legislature credit because they have looked at legislation to empower patients over the last several years. They've been advancing shoppable services legislation that requires each commercial carrier to have one shoppable plan that patients, if they do shop around and find lower cost services, can share in that incentive to do so. And they are pushing some transparency legislation as well. But the state of Florida doesn't have a setup like Medicare, CMS does to look at innovative programs for value-based and cost reduction. So they could do more in that arena, but they are looking at ways they can empower patients predominantly to be better consumers. So they definitely deserve credit for that.
So Larry, just for our audience, can you just define what Stark is? I mean, the people that are in the industry understand it, but I think we do a poor job with our consumer patient. What is Stark? And
Stark was born out of a guy named Stark out of California many years ago that basically said that physicians who own an entity cannot refer into that entity for profits. But again now, and as Fraser indicated earlier, Stark did inhibit many ways that we could practice more cost-effective medicine. And now that the value-based movement, along with accountable care organizations, have come along, there have been many waivers to the START program and in the way of care coordination, if it makes sense. So I think the START law, they're still there, they're still viable, and they're very enforceable. However, the START laws today, with the waivers that make sense for care coordination, are playing a bigger role in value-based care, John.
Thank you, Larry. All right, we want to open this floor up to questions, but before we go there, I'd like both of you to share about a 2-minute opinion about where you see healthcare is going, and then we'll open up the floor. Let's begin with you, Larry, because you just finished.
Okay. Well, you know, the move from fee-for-service to fee-for-value is definitely a movement in this country that every physician is going to have to engage and take on in their practice if they want to be successful. Payers, the people that pay the bill, as well as self-insured employers, are going to demand that we provide them as physicians and providers a more cost-effective approach to healthcare. And that's where the preventative and wellness comes in, John. And it's all moving to that to get a hold on this sustainable rising healthcare cost in this country.
Thank you, Larry. Fraser?
Yeah, the only thing I'll add, because Larry was totally right on that, and the one thing I've been really interested in the last year or so is the rise of the self-funded employers in direct contracting. there's been a recognition that we cannot sustain this track where we only have a few insurers that control all of the healthcare dollar that's spent and direct patients around. So I'm really interested when you look at the percentage of employers now that are self-funded and the flexibility that gives them in order to be able to provide more steerage to appropriate centers for care, that you can waive deductibles and make your employees, help them financially by just instructing them to go to a preferred provider that is transparent in cost or meets your quality criteria or whatever. You can, in self-funded employers can invest in these wellness programs to a larger degree. So they're becoming more of an important component. It's interesting to see the rise of them and the potential impact it's going to have on the BUCAs of the world, the major insurance companies, not to throw out jargon there. So that component is interesting to me, and if we'll see a shift, a decentralization, if you will, of who controls that healthcare, or giving more power to employers to determine care in their community. And the only other thing I'll mention is there was a drive for centers of excellence and medical tourism for a while that would take dollars out of communities and have employers sending their patients, say a Walmart would ship their patients to Tennessee for surgery. What I'm really excited about is the Health Rosetta movement that talks about the importance of lifting up physicians in a community locally and empowering them to keep those dollars in a community, help the local medical infrastructure take care and meet the same quality standards as they were seeking before, but make sure that care is delivered at home so it's more appropriate for the patients and it supports local infrastructure, local chambers of commerce, local providers, and do it in a way. So those two topics are not related to value-based care, but those are trends that I'm seeing that have really piqued my interest over the last year.
And John, if I could just speak one thing to what Fraser's saying, when you look at what are the threats to physicians today, particularly independent physicians, not only do you have the hospital purchasing practices, but you also have a tremendous influx of venture capital money coming in buying physician practices today. And we all know that it's documented that when a physician becomes an employee, patient care quality goes down and costs go up. And when venture capital take over physician practices that have been an independent physician practicing for 20 years in the market, also quality and cost go up. I mean, quality goes down and cost goes up. So those are the things that we have to balance as we move forward in healthcare.
Okay,
John,
can I ask, go ahead, jump in. Sure.
One other major trend too is the elimination of the inpatient only list and the drive for procedures to be done more in the outpatient arena in the community. That's going to have a major impact, maybe not in Orlando just because of the makeup of our hospitals and healthcare systems, but the drive of profitable surgeries away from the hospitals and what impact that has on them. The race to arm up, if you will, on ownership of ambulatory surgery centers and the ability to do practice-based surgery is going to be dramatic because those cases now can be done safely in lower cost centers in the community. And it's going to be really interesting to see what fallout happens once that revenue comes out of the hospital and health systems.
Right. And one clarification, John, there will always be a need for the hospital and acute care, always. But it's a matter of balancing the right care at the right place so that we're not sending patients to the ER on Saturday night for a bad cold and run up a $3,000 bill. That's and the hospitals don't want that either. They don't want those patients.
Absolutely. Now, I'd like to open the floor up, Dorothy and Andrew. I don't know how you manage that, but I think it's really important. All this gobbledygook phraseology. Let's open the floor up for questions from our audience. First question is, do you really see decentralization becoming a trend? It looks to me like the third party, and I lost it.
I can take that. It says, sorry, it looks like the third-party payer system that we have is leading toward federally provided medicine. I'm a fan of free markets. Do you see a way to allow market forces to help contain costs? Yeah, and I think that gets into the self-funded arena too. So rather than relying on a payer to administer your claims and your program, the self-funded employers have that flexibility. so you're seeing some decentralization take place there. Certainly there will be a continued drive towards more government-funded healthcare, but we haven't really been able to lower costs from a government-funded model either. Those costs for the Medicaid system, Medicare system continue to go up. So, I mean, I think this nation, if we go down ideological lines, will always have a component of private market as well as public market. Most of your socialized medicine countries in the world have a growing private health insurance market as well. So I don't see us going there. Certainly I see a rise in government funded care over the long run, but I think we'll always have a healthy private market as well.
Right? And you know, if the current administration had their way, I think we would go to a single payer system. And the question asked, I'm sure the person asking it, you know, is that viable? And the way that we're going to avoid a single payer system in this country is that if our physicians and providers and our educated consumers begin to understand how to access healthcare in our very complex market in the right way, and then privatization of healthcare will continue. But if we don't do that, you're absolutely right. It's going to move to a single payer system.
Yeah. And in a fully insured world too, there's no incentive to really hold down costs. So if you're just purchasing an insurance product, whether you spend a ton of claims this year or not really doesn't impact you until you start taking on some of that risk. So that's where the self-funded kicks in, because you're paying a premium target, but if you only spend half of that target, you get to keep that money. So it's not going to shareholders, to CEO salaries and things of insurance carriers. So there's that personal motivation to do what's right, to stay healthy, to utilize services in a responsible way, because you're going to share that savings on the end, which is where we need to get to. And that's going to prop up the private market when, you know, patients and employers have more flexibility and can reap the savings that come with utilizing services responsibly.
And in the self-funded market, Fraser, you can customize programs for your own employer and employee base to impact those costs. So, where in the fully funded arena, that doesn't work very well.
Sure.
Rebecca says our chronic uninsured population is not just doing preventative, as they do not have health care coverage at times. How can this transition to value-based care help the chronically uninsured population? Is there a solution?
That's a tough one, because if you don't have insurance, there's a good chance that you're not going to access the care that you need. You know, if you're familiar with the Affordable Care Act that was open enrollment October 15th to December 7th last year, the Biden administration reopened open enrollment on the ACA, and if you meet the income requirements beginning February 1 all the way to the end of August, the subsidies have tripled to where there are insurance plans out there under the ACA for people that qualify as an income as little as $50 a month, and the federal government is subsidizing through the CARES Act these new enrollees that are coming on board. And just so you know, since February 1, there have been over 1 million new enrollees in the Affordable Care Act. And again, I'm not promoting the Affordable Care Act. I'm talking about people that don't have care, that need care, that can then get a subsidy to pay for their premium so that they do have coverage to go and seek the care that they need, John.
Thank you, Larry. The floor is open. Any additional questions? Okay.
So there's a question from Ken Peach I see on here saying that COVID significantly impacted fee-for-service medical offices when patients stopped visiting and revenues dropped. Medical offices with value-based health contracts continue to be paid. Will this promote growth of value-based care? So Ken, just an initial reaction to that, there's some data coming out from the AMA of the number of medical offices that failed during COVID. So certainly the government assistance that was provided helped shore up a number of practices across the nation and in our community, but there were a significant number of physicians that either retired or they're just closed their offices because of that drop in revenue. So it probably will promote growth of value-based care, just because for those folks that were in that financial situation, many of them sought shelter in larger institutions or healthcare programs that, again, have the resources to invest in infrastructure to run these value-based care programs. So, I mean, obviously there is a transition towards consolidation, and certainly COVID contributed and accelerated that.
You know, the pandemic certainly created some vulnerabilities in our healthcare system, no question. But our physicians that were participating in value-based programs prior to the pandemic did survive fairly well from a revenue standpoint. The practices that were strictly fee-for-service, those are the ones that struggled. And I will tell you, of all of our physicians, we did have 2 practices that closed the doors after the during or just shortly after the pandemic. And the other thing that we're seeing is that, and it was estimated back in the fall of last year, that a lot of these hospital-owned practices would be leaving the hospital and joining the roles of the independent world again, because the hospital didn't want to handle that cost of those practices as well. So we're probably getting 4 or 5 practices a month right now of physicians that are leaving the hospital, wanting to enter back into the independent world and helping them reestablish themselves. So there is a little bit of a trend there.
I'm going to reach out to Dave Russell, who's been in this industry for a long time. He manages a large private practice with 6 locations, and I believe, Dave, a couple of surgery centers. What are you seeing at Digestive and Liver Center with the implementation of value-based healthcare? How do you like being put on the spot, Dave?
No, that's okay. We've taken a more tactical view of this. There is an inexorable trend away from fee-for-service to value-based payments. We understand that. And we're not fighting that trend. We're trying to become part of it. Let me back up 30 seconds with my experience with Community Health Systems, which is a hospital corporation and employed 3,000 clinicians across the country, and very complex contracts, and didn't pay much attention to value-based care, quite frankly. And their approach was to establish a primary care base as a strategic underpinning for their physician practice group. And on top of that, build specialists and subspecialists, which would feed the hospitals with procedures, with imaging, with surgeries. And that's why they owned, at a loss, a substantial loss, the medical groups. Larry, you've noticed that there's been some leakage from the hospital corporation ownership model back to private practice. I don't doubt that at all. What we have seen from this private practice that I'm with now is that the hospital corporations are very open to do business with us because we're doing well, I suppose, and have a differentiating set of characteristics. But we're also willing to accept at least our version of a risk-based model. And so what we do with them is, for example, we'll place in their heavily trafficked clinic a patient navigator. And that navigator is a clinician, and that clinician will be able to talk with the physician down the hall when they see a patient that they feel needs to go to the hospital or be admitted because of a GI or colorectal problem. And we can often then hook them up immediately with a curbside consult with one of our partners or physicians. And we give out those cell numbers to all the physicians we do work with across the city here, so that we can line up a visit immediately, same day, even same hour, free transportation, get them over to our clinic and avoid that unnecessary, in many cases, ER visit. That's an expense that they don't have to encounter. And those risk-based medical groups, and there are a lot of them in town here, particularly Medicare Advantage, et cetera, that we can help out that way. Second, we offer a capitated rate if that's what a group wants to do. I'm working with one of them right now. Not an easy set of math, but we can offer that, and that's another way to trim costs. But it's a more tactical view. It's not a 40,000 foot view of how we go about approaching value-based care. It's putting our folks in their practice, offering them curbside consults, working with payment models that flatten the spikes, and just a few suggestions.
Thank you. And the final question, Rosellen asked, do you really see decentralization becoming a trend? It looks to me like the third-party payer system for insurance that we have is leaning towards federally provided medicine, federally funded provided medicine. I'm a fan of free markets. Do you see a way to allow market forces to help contain cost? Larry and or Fraser, you want to bring us out with this?
Sure. I'll just speak to this for a minute, let Fraser end it up. The data is going to determine whether that happens or not, John. As I indicated earlier, physicians have to do their job. They have to be the conductor of healthcare, particularly the primary care physician is the gatekeeper, if you would, or the conductor of patient care. And even more important, the consumer has to become an educated healthcare consumer so that we're approaching healthcare and navigating our way through this complex healthcare system in a cost-effective, high quality manner way. If we do that, I do believe the healthcare system can survive as an independent and not become federally completely controlled.
Fraser, last comment on that?
Yeah, the only other thing I'll say is physician leadership and engagement is key. All the successful value-based programs we've seen have had strong physician leadership involved. We can't have physicians check out as they become employed or bought by venture capital if we're going to make these systems effective. So we need physician engagement. We need physician leadership. That's really important. And just one other comment, there's been some chat. Obviously, this conversation's been about providing care where patients have access to insurance. Orange County and the whole region does a fantastic job with the uninsured programs that we have. The PCAN network and others are a model for communities around the state. So, that wasn't the focus of today's conversation, but I did want to give a shout out to all those folks that work in PCAN and Grace Medical Home and some others that do take care of those patients that fall outside of the insurance market, if you will, and unable to avail themselves to these value-based programs we've been talking about.
Yeah, and before I hand this back to Andrew, I'll jump on that. PCAN, Shepherd's Hope, True Health, community health centers. I mean, this community is really blessed, and Grace Medical Homes. I apologize if I had left in, but Andrew, do you want to bring us out with any final comments?
No, I appreciate everybody that's been here on the call and the information that's being shared. And just to throw some things out there, just to, if there's ever any advocacy pieces or initiatives that any of the organizations or businesses, as a member of the East Orlando Chamber, you can bring that to our Advocacy Advisory Council to go up towards Tallahassee and to advocate for those measures if there's things within the industry. So I just want to make sure that you're aware of some of the things that the Chamber is doing. We did put out some information regarding the Medicare when they were looking of cutting that. So I just wanted to let people know that the Chamber is here as a voice for our businesses and industries here in Central Florida. So with that. But otherwise, I really appreciate all of our speakers and everybody that has stayed on today. And we do this monthly. and spread the word, spread the news that we like to provide great information and connections here on our collaborative, the East Orlando Chambers Healthcare Collaborative here. So thank you for all your participation. If you have any other questions or anything from there or would like to reach out to anybody, please let us know and we can put you in touch with those folks. But we look forward to having you back on next month. And any other questions about anything, please let us know. John, anything else I'm missing on your end?
Healthcare Now, 1 o'clock Saturday afternoons, 94.9, 9:50 a.m.
You got it. All right, everybody. Well, thank you very much. We really appreciate your participation. We look forward to having you next time. And thank you for all the great information you've provided for us this morning.
Thank you, Andrew.
Take care, everybody. Thank you all.
Thanks, Fraser.
Yeah, thank you all.